Hi everyone, welcome to chapter 22 in AP2. I thought we'd go over the anatomy of the respiratory system given our lack of class time over the last couple of weeks. So we'll start off with the diagrams that I provided to you in class, and I'm just going to label it over here, and then you can check your answers against these, what we've been doing over here. So let's start off with, labeling the various structures that I'm going to draw a line to over here. So we'll start off with here, that little structure. That, as you can see, is a covering on the lungs, and that's really the parietal pleura. We'll talk more about the pleural spaces in a bit. The visceral pleura directly touches the lungs itself, and you can't really see it over here, but that's how it appears. You can see the parietal pleura. The visceral pleura is just a shiny surface on the lungs itself. So in terms of the lungs, they're labeled as the right lungs and the left lungs. That's pretty easy, so maybe we should do that first of all. So that's right, and this is left over here. The lungs, as we all know, have several lobes, which is actually better represented on the diagram over here. So let's do the lobes actually over here, and then we'll relate it to the prior diagram. So as you can see, the right lung has 3 lobes labeled as the superior lobe of the right lung. Then, sorry, this is the left lung, and this is the superior lobe of the that's the left lung. It's not a auspicious start when you get left and right lung, but here's the superior lobe of the right lung, and this is the inferior lobe of the left lung. Okay, left lung there. So both of these over here, and that's on the posterior side. This is on the anterior view. So on the left lung, we only have 2 lobes. The left as the superior and inferior lobe, and they're separated by this fissure over here, which is called the oblique fissure. And since there are 2 oblique fissures, one on the left and right lung, we have to be a little bit more precise. This is the oblique fissure of the left lung, whereas on the right lung there are 2 fissures over here. So this is the oblique fissure of the right lung, and similarly the oblique fissures, as you can see, goes all the way across the lungs, all the way onto the posterior side of the lung, and right up to the mediastinal surface. So in both the left and right lungs, you can see the oblique fissure goes pretty much all the way. Now, the reason why the lungs are divided into lobes is so that if you have a collapse of a lung, it might just be restricted to one lobe rather than affecting the entire lung. Similarly, you can resect one lobe or even one section, as we'll see, of a lung, as opposed to the whole lung, which obviously you can't do in, say, in the heart. You either remove the entire heart or not. Here you can remove a part of the lung because of the division of the lungs into the various lobes, and as we'll see, segments as well. So this is the oblique fissure of the right lung, and this is also the inferior lobe of right lung. And where is the inferior lobe of the right lung? Here. Here's the inferior lobe of the right lung. So we have the superior lobe, we have the inferior lobe, and right in the middle we have the middle lobe of the right lung. The oblique fissure separates the middle lobe from the inferior lobe on the right lung, and it's this horizontal fissure that separates the middle lobe from the superior lobe of the right lung. So this is the horizontal fissure of right lung. There's only one horizontal fissure, but anyways, we can make it a little bit more precise over that. So superior, middle, inferior lobe, and on the left lung we only have the superior and inferior lobe. But sometimes they also refer to as the upper and lower lobe of the left lung, and the upper and lower lobe and the middle lobe of the right lung. Since this is anatomy, we'll stick with superior and inferior, but upper and lower is not incorrect either. So those are the lobes of the lungs. Let's go back over here to the first diagram and label all the structures that we see. So we have the parietal pleura on the lungs, and let's label the fissure. Here you can see that's the oblique fissure. Actually, in the anterior view, you can barely see the oblique fissure. So oblique fissure of the left lung, and over here you have the oblique fissure of the right lung. One thing I just wanted to notice, maybe I can go back over here. This little notch that you see here on the left lung, and the reason why the left lung is smaller, is called the cardiac notch. And that's obviously where the heart sits. So the left lung is smaller because the heart more or less butts into it and takes up that volumes of space. Here, in the first diagram, it's a little bit hard to see because the left lung is kind of reflected, but otherwise the cardiac notch will be right here. And this is where the heart sits. In fact, this is the pericardium, and the heart has obviously been removed over there. So that's the pericardium that's attached to the diaphragm, and that's the diaphragm. We all know the heart rests on the diaphragm. Similarly, the lungs also rest on the diaphragm itself, so you can see this concave aspect of the lungs that sit on the diaphragm here. So going back over here, this is naturally the superior lobe of the right lung, and you can barely see the inferior lobe of the right lung on the anterior view, and we should always label the view. This is the anterior view. So inferior lobe of left lung, and here we have the, there's the inferior lobe of the right lung. This is the middle lobe of the right lung, and here's the superior lobe of the right lung. And lastly, this is usually called, let me go a little bit up, that's called the apex of the lungs. So here's the apex, and what sits on the diaphragm is the base of the lungs, right, which is concave, and there's the apex of the lungs. Okay, that's oh yes, so it's just a horizontal fissure, right? So this is the horizontal fissure here. And that's pretty much it in terms of the lungs itself. A few more respiratory structures. Here's the trachea, which divides, although it's blocked by these great big vessels, into, you could just barely see, here's the, where it's dividing. That's the right primary bronchus. And you can just barely see it over here. The left primary bronchus. And then the primary bronchus will divide into the lobar bronchi, to the two on the left. Here's one, here's the other lobar bronchi. So we can see that's the secondary or lobar bronchi. And similarly over here, it divides into three because there are three lobes. So that's also the secondary or lobar bronchi on the right lung. And then you can see that we have 22 to 24 orders of subsequent branching over here. Other than that, we can't really say much about the respiratory system itself, but all the other structures are related to the heart and the digestive system. I'll just label this. This, if you haven't already figured it out, is the esophagus, which lies posterior to the trachea. So you can see the esophagus over here. It's behind or posterior to the trachea. And then here's the esophagus, which is typically obscured by the heart. Here the heart's been removed. This is the pulmonary trunk over here that divides into the left and right pulmonary arteries. Here's the aorta, ascending aorta, aortic arch, etc. These are the brachiocephalic veins. That's the right brachiocephalic vein. That's the left brachiocephalic vein. And the brachiocephalic veins are formed by the confluence of the subclavian veins over here and here with the internal jugular veins here and here, right? We did all that when looking at the different blood vessels. And this is the superior vena cava. Similarly, this is the thyroid gland, which is obviously not part of the respiratory system. Okay, just a couple of things. So we already mentioned this is the pulmonary trunk. Since it's bringing blood to the lungs, we might as well mention it. So that's a pulmonary trunk that has been severed. Oops. Trunk. And here's our left and right pulmonary arteries. So this one's the right pulmonary artery, and I'll leave it to you to label the left pulmonary artery. Similarly, these are the pulmonary veins for typically. So these are the right pulmonary veins. Oh, where do I have space here to write it out? There we go. Oops, that was bad. But anyways, so those are the right pulmonary veins that brings blood back from the lungs into the left atrium. Here's the aorta as mentioned, aortic arch, and then the descending aorta, and this is the thoracic aorta. And that's pretty much it. Just about the parietal pleura, it's given a couple of names. This is the mediastinal surface, because it's pointing towards the mediastinum where the heart is, and this is called the costal surface of the parietal pleura. And then you even have the diaphragmatic part of the parietal pleura over here. So you can see the parietal pleura completely is on the outside surface of the lungs, and it's also attached to the chest wall itself on the diaphragm, and then onto the ribs itself, as we'll see. Okay, so that's pretty much it in terms of this diagram. We already did the diagram below for the different lobes of the lungs. Make sure you do that. Now let's label this particular cadaver photo. We're not going to label all the different structures of here, just a couple of blood vessels and obviously everything related to the respiratory system. So just so that we just go in particular numerical order, number 2 over here, which is this structure here, this is the right internal jugular vein. And the corresponding structure on the other side is here. That's actually not even labeled over here. So that's maybe 19. I think it skipped a few numbers over here. Yeah, that's probably 19. So 19 is the left internal jugular vein. Okay, then number 3 over here, this tiny structure over here that you can barely see. Or maybe if I use a highlighter, let's see. Where do I have it? Draw. Here's the highlighter. There's the thing. Oh, it's not. Well, I guess I did do it. So here's that structure over here that you can barely see. Maybe I'll just draw it in blue here. That structure over there. That is the vagus nerve. And we all know that the vagus nerve is the main parasympathetic output from the autonomic nervous system over here. Number 4 is the right common carotid artery, which is one of the branching of the brachiocephalic trunk that comes off the aortic arch. So you have from the aortic arch, you have the first brachiocephalic trunk that then divides into the right subclavian artery and right common carotid artery. Then we have the left common carotid artery, and then we have the left subclavian artery, if you remember. So maybe we're getting too bogged down with all these blood vessels. But anyway, it's good revisions for chapter 19 as well. Over there, number 5 is the right subclavian vein, which combines with the right internal jugular vein to form number 6, which is the right brachiocephalic vein, which combines with the left brachiocephalic vein to form the superior vena cava, which is number 7. That's the superior vena cava. Okay, number 8, now we're into the lungs itself now. So 8 is the superior lobe or upper lobe of the right lung. Then that arrow that's pointing there, that's the horizontal fissure. Nine is actually the heart, so maybe we'll go down here. I will do it here. 9 is the right auricle, and underneath that is the right atrium. 10 is back to the lungs. 10 is the middle lobe of the right lung. Eleven is the oblique fissure of the right lung, and you can notice that you can barely see it in the anterior view. Similarly, you can barely see 12, which is the inferior lobe of the right lung. 13 is the diaphragm. You can see how big the muscle is over there. Then this is 14, really. Where am I? Where's my little pointer? Oops, not there. Yeah, just skipped. 14 is actually the falciform ligament, which is a remnant of the umbilical arteries and veins. So we're not going to label it here. We'll do it when we do the digestive system next. 15 is the costal margin over there. Oh, 16 is the digestive system. It's really actually the transverse colon, so I'm not going to label it right now until we do the digestive system. 17 is the thyroid gland. So again, not part of the respiratory system, so we'll put it over here. 18, yes, we're back to the respiratory system, is the trachea. 19 and all that are blood vessels, so I'm not going to label it, but they're similar on the opposite side. 19 is the left internal jugular vein. 20 is the left brachio. Where's 20? That should be 20 over here. Over there. 20 is the left cephalic vein that's coming up from the arm, really. 21 is the left brachiocephalic vein. 22 is the cut edge of the pericardium that you can see. So the pericardium has been removed, so now you can see the heart itself. 23, back to the respiratory system, so let's label that. That's the superior upper lobe of the left lung. Oops. "24" is back to the heart. That's the right ventricle. 25 is the left ventricle. 26 is the anterior intraventricular sulcus, and underneath that is the intraventricular septum. So 27 is the inferior lobe of the left lung. Please notice once more that you can barely see the inferior lobe on the anterior view. 28 is the xiphoid process, actually. That's part of the sternum. 29 is the liver, or more specifically the left lobe of the liver. 30 is the stomach. Again, these are the part of the digestion. And that's about it. So let's move on to look at the next diagram over here. So this is another cadaver view, except this is in a sagittal section of the entire upper and lower respiratory tract. So we're not going to label everything again. Just a couple of things. One is the sphenoidal sinus, or the sphenoid sinus. Sinuses are egg-filled spaces within the skull that are used to essentially lighten the skull itself. So 17 is also a sinus, so I might as well label it here. 17 is the frontal sinus. Okay, 2 is the opening of the, or pharyngeal opening of the auditory tube, which is also called the tympanic tube, which is also called the eustachian tube. So all names are acceptable, really. So opening of the, we'll just call it the auditory tube, or pharyngotympanic tube, or eustachian tube. All three are really the same thing. So in a child, that particular tube is really narrow and very horizontal, and that's why children are prone to developing middle ear infections or otitis media. In an adult, that tube becomes more wider and less horizontal and becomes more oblique, so it's more easily drained, and as a result, we're no longer susceptible to developing middle ear infections. Number 4 is actually the one of the vertebrae. I think that's the C2, and it's the dens of the axis. 5 is the oropharynx. So the pharynx itself is divided into 3 parts. The nasopharynx, which is over here. Maybe you can label it in red. So this is the nasopharynx. This is the oropharynx. And then we have the laryngopharynx, and then the larynx itself. So let's go back over here. So 5 is the oropharynx. 6 is the epiglottis, which closes off the esophagus. Closes off the larynx when we're swallowing food or drinking water. 9 is where's 9? Here, that's the upper lobe of the right lung. 10, was 10. 10 is that's not the pulmonary arteries or veins. I believe that's the zygous vein. Not important. 11 is the branches of the pulmonary artery. Of the right pulmonary artery. 12 is the right main bronchus. 13 is the right at the bifurcation of the trachea, which is also given a name, which is the carina, which is the bifurcation of the trachea. 14 is the branches of the pulmonary vein. So you notice that the pulmonary arteries are superior to the pulmonary veins at the hilum of the lung itself. 15 is the middle lobe of the lung. A little bit hard to see over here in this view where the lungs are kind of splayed open that way. Sixteen is the lower lobe or the inferior lobe of the right lung. Now 17, we've gone back on to the superior part of the diagram. So 17 is the frontal sinus. 18 are the concaves and so forth. So 18 is the superior nasal concave, and I'll explain the concave in a second, what its function is. 19 is the middle nasal concave, and 20 is the inferior nasal concave. So the concave, as you can see, are little bulges in the not quite the septum, but on the bony part. In fact, the inferior nasal concave is a separate bone when you're doing the accounting of the different bones in the skull. So what they do is to create turbulence in the nasal cavity. So now when air is inhaled through the nose, it has to go through these big ridges, and it has to go through the meatus, which is in between the concave. So if I use a different color over here, so let's go with green. So this is the meatus. So this is the inferior nasal meatus. This is the middle nasal meatus, and this is the superior nasal meatus. So all this does is creates turbulence for the air that's coming in through the nose, and as a result, all the heavier particles, the dust and so forth, are deflected and get trapped in the mucus, and only pure air or filtered air now can enter into the pharynx. So in this way, everything is filtered that has a diameter of less than 0.5 microns, so pretty effective when you can see. So essentially what the nasal concave do is to create turbulence so that the heavier particulates in air get deflected and get trapped within the mucus linings of the nose. Okay, so that's the concave. 21 is the hard palate. Oops, we don't want it in green. Let's go back over here. That's the hard palate, made up of mainly the palatine bone. 22 is the soft palate, and with the uvula, that this is really the uvula. '23 is obviously the tongue. 24 is the vocal fold. So we're not really going to focus on the larynx itself, but there's a vocal fold and a vestibular fold, so we're not going to see how the sounds are produced in the larynx. That's beyond the scope right now for this chapter. 25 is the larynx itself. Please remember how to spell larynx as well as the pharynx. 26 is the trachea. And then 27, we go to the different parts of the left lung now. Oops, too far down. So 27, that's the upper lobe or superior lobe. You can see I switch back and forth, but this being anatomy, we should probably stick with superior and inferior upper lobe of the left lung. 28 is the left pulmonary artery. You notice that hasn't yet divided because the left lung is closer to the trachea than the right lung, and it only has 2 lobes as opposed to 3 lobes. So that's the left pulmonary artery, whereas the right pulmonary artery is pretty much already divided. You can see that. Remember, that's the 11 is the branches of the right pulmonary artery. 29 is the left main bronchus. 30 is the left pulmonary veins, 2 of them you can see. Again, notice how the pulmonary artery is superior to the pulmonary veins at the hilum of the lungs. And lastly, 31 is the lower or inferior lobe of the left lung. Okay, now let's go on to the pleural. Although we did cover a little bit of this in class, let's do it again. So you can see, in terms of the pleura, this is the parietal pleura that covers the outer surface of the lungs and it's attached to the chest wall over there. So that's the parietal pleura. The visceral pleura is directly attached to the surface of the lungs, and you really can't remove it. It's just a shiny, glossy thing on the surface of the lungs, right? It's like saran wrap. You often heard me say this. It's like saran wrap that you use to wrap your vegetables, etc. It's just a thin, translucent film on the surface that you can't really actually remove. In between, we have the pleural cavity. And so now we have to talk about the pressures. The pressure in the lungs is the intrapulmonary pressure, which in between inspiration and expiration should equal to atmospheric pressure. So all this is physiology, which I'm not going to cover over here. We did this separately. But remember, atmospheric pressure, air comes in. When during inhalation, the diaphragm drops. You create a slight lowering of the intrapulmonary pressure, and that draws in air from the atmosphere into the lungs. Now, just before we exhale, the atmospheric pressure is equal to interpulmonary pressure, and that's typically 760 millimeters of mercury, right? Because that's what atmospheric pressure is, 760 millimeters of mercury. And then when you exhale, the diaphragm rises, the volume of the thoracic cavity decreases, so the interpulmonary pressure increases above 760, and then you exhale and air moves out until it's back at 760. So that's how inspiration and expiration occurs. But the interpleural pressure, the pressure in the pleural cavity, is a little bit different. That's is less than 760. So it's usually 754 millimeters of mercury or so. So we say it has a negative pressure. It only means negative because it is less than interpulmonary pressure. So interpleural pressure is usually about 4 to 6 millimeters less than interpulmonary pressure. The reason why you need a negative interpleural pressure is to make sure that the visceral pleura remains attached to the parietal pleura. Now remember that the parietal pleura is attached to the chest wall. It's attached to the ribs on the costal surfaces, it's attached to the diaphragm, it's attached to the mediastinal surface as well. The visceral pleura is attached to the lungs themselves, but remember the lungs are very passive. They're just like little balloons, and it's only the changing of the size of the thoracic cavity that enables the lungs to change in size as well. And all this is a passive process. Remember, breathing is not active, it's just passive. So as long as the lungs change shape, or more accurately volume, with respect to the changing volumes in the thoracic cavity, air will be able to move in and out of the lungs. But what causes the lungs to remain attached to the chest wall is the pleura. So when you have a negative intrapleural pressure, that creates a slight vacuum. The visceral pleura now remains stuck to the parietal pleura, and in essence, the lungs remain attached to the chest wall and the diaphragm. Now, when the chest wall and the diaphragm move, the lungs move along for the ride, and as you move the lungs along, the pressure changes and you can get inspiration and expiration. All this is physiology, which I didn't really mean to explain over here, but that's how it works. But make sure, in terms of the anatomy, that you're able to label the visceral and parietal pleura. Okay, let's move along. In the last diagram that we're going to label is the spirogram over here. Now, we did this in the lab a little bit, but let's just refresh our spirogram and be able to label the different volumes and capacity. A capacity is simply a sum of two or more volumes. Okay, so a couple of things that we have to label here, and we'll use abbreviations and then define the abbreviations. Here we have regular breathing, which we call tidal volume, or TV. So TV is tidal volume. That's the amount of air that moves in and out during inspiration and expiration. That's usually about half a liter, or 500 mils over there. So during regular breathing, we don't make use of the maximal amounts of air that can move in and out of the lungs, but if we need to take a maximum amount of breath over there, that's called the inspiratory reserve volume, or IRV. So this is a deeper breath as you can inhale. So IRV is inspiratory reserve volume. And that will depend on your gender, age, height, etc. And there are various predictive algorithms that you can use to figure out what your predicted IRV would be. But the reason why we don't usually measure IRV itself, what we are most interested in is vital capacity. So this is the experiment that will do or have done in the lab, and that is to measure vital capacity. So you take a deep breath in, which is exactly what inspiratory reserve volume will be, and then you exhale as hard as you can, as long as you can, and that will take you to your vital capacity. So before you just get to vital capacity, once you take a deep breath in, and then when you exhale as hard as you can, this is called the expiratory reserved volume, or ERV. So ERV is the expiratory reserve volume. As you can see, the expiratory reserve volume is smaller than the inspiratory reserve volume. And let's just finish up with the volumes before we go on to the capacity, which is just the sum of these various volumes. So what we can't exhale out from our lungs is referred to as the RV, or residual volume. Right? So that's the amount of air that remains in the lungs at all time. And that's because if you exhale out everything, every last bit of air in the lungs would immediately obviously collapse, and then it would take great pressures to reinflate the lungs again. So there always has to be some air remaining in the lungs, and that's because it has to do with the compliant nature of the lungs. Similarly, that's also why we need to have the negative pressure, intrapleural pressure, because as soon as the intrapleural pressure equals to the intrapulmonary pressure, this is on the previous diagram, then the lungs will collapse because there's nothing holding the lungs on to the chest wall. And the lungs, being very elastic and compliant, will immediately shrivel down, collapse, and all the air will escape. Just like a balloon, when you let go of the air in the balloon, all of the air just escapes out. So that's why we need to have some residual volume in the lung to prevent it from completely collapsing, because then if you exhale out every last bit of air in the lungs, then it becomes very difficult to reinflate the lungs again. Let's move on and talk about the various capacities over there. So the most important capacity is the vital capacity, which is right here. This is VC. VC equals to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. That's vital capacity. So VC is vital capacity. Vital capacity is the maximum amount of air that you can move in and out of your lung. And that's something that is measured through spirometry, which we'll do in the lab itself. So vital capacity gives you an indication of the health of your lung. As you can anticipate, a lifetime of smoking will destroy your vital capacity or significantly reduce your vital capacity. You can, based again on your age, height, gender, weight, etc., you can use these predictive equations to calculate your predicted vital capacity, and then you can see what your actual measured vital capacity, how it compares to your predicted vital capacity. If it's within 20%, you're good. Obviously, a lifetime of smoking, your vital capacity, measured vital capacity, is going to be a lot less than your predicted vital capacity. It could be less than 50% even. If it's less than 30%, you're completely debilitated. So that's vital capacity. The other one that we want to look at is TLC, or total lung capacity, which is the total amount of air that can exist in your lungs, and that's simply a sum of all the volumes. So it's IRV plus TV plus ERV plus RV, residual volume, right? So you can also measure total lung capacity, but it's less important because we don't exhale out the residual volume, but I won't go into how we can measure that, but you can measure total lung capacity as well, and hence get an indication of residual volume. All right, there are a couple of other capacities. Inspiratory capacity, again, this is not very important. IC, inspiratory capacity, is here. That's inspiratory capacity. This is TLC, total lung capacity. Inspiratory capacity is just IRV, inspiratory reserve volume, plus tidal volume. So that's the maximum amount of air that you move, that you can inhale, right? So it goes from here to here. That's the maximum amount of air you can inhale. Usually we just inhale this amount from here to here. That's for tidal volume. Similarly, expiratory, and so inspiratory capacity and expiratory capacity. So that's EC. Expiratory capacity is just tidal volume plus expiratory reserve volume over there. So that's going from here to here. Is that labeled even? No, that's not even labeled over there. So lastly, this one here is functional residual capacity, FRC. FRC is functional residual capacity, which is just the amount of air that remains in the lungs after a normal expiration. So if we expire as hard as we can, you could reach at the bottom. That'd be expiratory reserve volume will be expired out as well. And so functional residual capacity is the amount of air that typically remains in your lungs after regular expiration, and that's equal to functional reserve volume. Let's write that again. Oh, so sorry, functional residual capacity. And that is equal to expiratory reserve volume plus residual volume. So that's usually the amount of air that remains in your lungs during regular breathing, right? So functional residual capacity. So what's key is to be able to label IRV, inspiratory reserve volume, tidal volume, expiratory reserve volume, and then vital capacity as well. So the most important capacity is vital capacity. That brings us to the end of this particular lesson on labeling these anatomical diagrams related to chapter 22 on the respiratory system. Please make sure that you label the diagrams and then check your answers by watching this video. Thanks, have a great day. Bye.